Hi everyone, I'm Liliana. I'm going to be presenting today my capstone project, and I have decided to do my capstone on physician order errors, and I named my project Snowball Effect of Physician Order Errors. I'm going to start this presentation with some basic information. Every time when we have a patient in radiology department that needs to have some service, first and basic things that we ask from patient is doctor's order. Doctor that writes order to the patient is commonly called the referring physician, and every order, in order to be valid, has to have some information, basic information on it. So we need patient's name, last name, first name, date of birth. We need diagnosis. We need exam that's requested by referring physician. And of course, it's very important that every order is signed by the doctor or referring physician. These orders can be delivered to the radiology department different ways. Patient can bring order with them, the written order. They can be faxed over to us, they can be mailed, they can be electronic orders, or they can be verbal orders over the phone. This variation in management and delivery of these doctors' orders are resulting in some inaccurate data collection, ununiform patient care, and of course inability to track these orders before they come to radiology department. What's the reason and why I actually decided to do a capstone project on physician order errors? Well, since I started in this hospital where I work right now, Mercy Hospital, it's been almost 2 years, and this problem is persistent and doesn't seem like it's getting any better. So when I talk about the issue that's bothering the most my department, I thought about this problem, and that's main reason I decided to do my capstone on this. So after I made the decision, I had to do research, and my research actually started with my manager. She's the manager of the breast center, and I talked to her, and actually the first thing was to actually find out how many orders per week, per day, per month, let's say, have an error. So after talking to her, we kind of came to conclusion that approximately between 5 and 8% of all physician orders in mammography in breast center where I work have an error. This is a big issue because every time when we have a patient with wrong order, that's causing a lot of trouble in our department. At techs, they can't do what they're supposed to do, which is performing exams and delivering patient care. We have to solve this problem and deal with the error. And then other patients that are scheduled, their wait time is increasing. It's causing backup in schedule, and overall patient satisfaction is going down. Large amount of hours that we spend are actually spent on fixing these errors instead spending time with the patient. Now question is, who made a mistake? Who caused the error in an order? Well, most common error is that ordering physician who wrote the order made mistake. Most common mistakes that we see in these orders are, first of all, ordering wrong test. So physician orders screening and diagnostic has to be done, or vice versa. Second mistake they all make many times, it's they put incorrect side for either a diagnostic mammogram, biopsy, ultrasound, cyst aspiration, whatever it is. So they put left and it's right, they put right, it's left. Another error they do, it's when patient is sent for diagnostic exam because patient's complaining of the lump, or not even patient doesn't know that has a lump, but doctor felt a lump. They put diagnostic order, but they don't actually mark the area on the breast where the lump is present. So without that location where the lump is present, we cannot proceed to the exam. So this is considered the wrong order. And one issue that's very common also, when patient has a diagnostic order, they need to have breast ultrasound order complementing that order. Otherwise, we cannot proceed to do exam. A very small number of these orders are lost by patient or physically lost when they fax over to our location, but that's a very small number. There are other factors that contribute to this problem and make physician order errors even a bigger problem. Each institution has their own rules and protocols, and each radiologist, they make up their own rules, and of course we as the technologists, we have to follow them. For example, in my breast center where I work, radiologists require diagnostic mammogram every time after patient undergoes lumpectomy, regardless how many years it's been passed by since that lumpectomy. So every time the diagnostic order is required. Another rule that we have in our department is that 7 years after patient undergoes mastectomy, if no new or enlarging lumps are present, patient can go back to unilateral screening on the side that they still have present. Also, another rule that we have is diagnostic mammogram must be accompanied with breast ultrasound, otherwise it cannot be done, because 90-95% of the time when we have diagnostic mammogram that requires additional testing and ultrasound. Of course, I had a presentation last year in my last class, I believe, about contradictory and conflicting mammography guidelines, because each organization, like American College of Radiology and other organizations, they form these guidelines. They have different opinions when to start mammogram, how often has to be done. So this not confuses only patients, but confuses also physicians, and part of the whole problem is that whole confusion. Interesting fact is that a few weeks ago I had a patient who came for a screening order, and I asked her, oh, you haven't been here for 3 or 4 years? And she said, yes, I wanted to come, but even this time I had to fight with my doctor. So I was real confused. I asked her to explain, and she said, well, my doctor believes that I don't have to come every year. I have once in 7 years is just enough for women to have screening mammograms. So she said, I felt I need to come more often, and we kind of had a little argument, and he finally decided to give me referral for screening mammogram. I thought that's really odd, and I can see how that can be the problem for our department. And also, some physicians are not willing to educate patients, especially after all these contradictory and conflicting mammography guidelines came up. Most of the organizations concluded that the best approach would be if physicians discuss with their patients their first personal history, their family history, and then patient is always the one who makes decision how often they want to have a mammogram, when to start, and what would be the best option for them. Who is affected by all these physician order errors? Of course, patients, they're mostly affected with this. This mammography exam is the exam that's scheduled sometimes weeks and months ahead. And of course, many times patients, they have to take days off work to come to this appointment. So when we have a patient who's waiting, who took day off from work, and we go and tell them, well, I'm sorry, I cannot do your exam because you have a wrong order, of course, what we can expect, that patient is frustrated, they're mad, they don't understand what's wrong with the order. So it's mostly affecting them. It's delaying patient care. Sometimes time is very crucial in many of those exams. And they're losing trust in our organization because how come this is happening? Secondly, technologists, mammography technologists are affected. I'm one of them. When I have a patient with physician order, I have to leave whatever I'm doing right now, and instead proceeding to exam room and doing patient's exam, I have to go first talk to patient, explain them that they don't have a order that's required for this exam today. The one they have, it's wrong. Then I have to back talk to my manager, and then most of the time she comes, she explains, she tries to contact the physician and obtain right order. So the patients that are scheduled later on after these patients, they get additional wait time, we get backed up, and it's frustration on both sides, patients and technologists. Management is also affected. My manager, she's affected also with these errors because she's the one who has to obtain new correct order after we have a wrong one. So she's the first person I go to, and then of course next step is she needs to figure out what do we need, and she tries to reach the doctors. They wrote the order, and she tries to obtain a new one. Sometimes that's a very difficult task because they cannot be reached. She paged them, sometimes they're out of town, or office is closed on some days. So you can imagine frustration in that part. And physicians, even though they made errors and make a mistake, they get annoyed by all these calls to correct orders because they're incorrect, and many of them are fearing to appear and knowledgeable how to order mammography exams. So they're also affected by these errors. What is the solution for this problem? Well, best approach would be that we prevent these errors from happening before they happen, before patients get wrong order, before they call central scheduling, they schedule for exam, they come to the radiology department, press center, they register their weight, and then finally, after all these steps and wasted time, they find out that they cannot have this exam. So that would be ideal. This means that, like I just said, there are few steps the patient has to go through to finally get to the exam. So I realized that this means we need to address this issue at a few levels. First, we need to address this at the physician office. That would be the most effective. That's where error happens and when the place where error happens. Then central scheduling, registration at front desk, and patients themselves. First step, of course, the most effective one and most difficult one would be the educating physicians about how to put correct order and which patient qualifies for which type of the exam. It's very difficult because it's kind of difficult to find the right approach to tell doctors and not offending them. So after talking about the whole this issue and what's the best way to solve this with my manager, actually one day when we were sitting and talking, she told me, oh, this never occurred to me, but now when I'm talking to you and thinking more about this problem, I just realized that I can actually go, instead calling the doctors, I can go and talk to medical director, chief medical director in a hospital, who's actually in charge of all doctors and residents. So, and I thought that's a great idea. I didn't even know that we can do that. So after conversation we had, we realized we can provide bulletin or cheat sheet for the doctors, and he can deliver those bulletins to each physician, and he can talk to them, and then I believe the doctor would be more receptive to listen to him than just from getting calls from the techs or the nurses or managers about the orders. They're going to be more receptive to those suggestions. Also, one of the solutions for the problem is, and we are actually already doing that, we have those blank orders, and those are sent every month to the doctor's offices, independent doctor's offices, and as well as the doctors, they belong to the Mercy system. And these orders actually are kind of self-explanatory, and it's very easy to follow these, because there is just place to put, of course, patient name and date of birth, and then later on you can just, by checking the boxes, going through all these boxes, actually, physician, it's very easy for them to order this exam. So for diagnostic, for example, breast evaluation, you can check palpable lump or history of the breast cancer, or follow-up exam, 6 months follow-up, 3 months follow-up, doesn't matter. So not only these orders, they have appropriated boxes to check, but each of these exams has codes, diagnosis codes that reflects the test and the type of test the patient is supposed to have. This is actually great because this ensures when radiologist looks at this order, they have also the code next to the diagnosis, and then this way they can make sure the patient receives correct screening or diagnostic services. So this would be one of the other ways how to approach this problem. So that's what I was talking about. So we can check the lump or history of breast cancer, we have codes next to it, and also it says here that diagnostic breast evaluation includes mammogram, sonogram, cyst aspiration, fine needle aspiration, ductogram, or any other additional testing. So this solves problem and covers all the bases. Next step would be educating central scheduling. As I said before, patients have a wrong order and they make a call and they want to schedule their exam. So there is still, error is already made, but there is still a chance we can catch this error before a patient goes through all these steps and comes to the exam and waits and then finds out they have incorrect order. Problem with central scheduling is that the majority of the staff that works there are administrative staff, and they have no medical background or education, and it's very difficult for them to differentiate between different types of exams and what patient needs to be scheduled. But the solution for them would be also creating some kind of script or cheat sheet, and they can ask patient questions, and answering those questions would give them some more understanding which type of exam they're supposed to schedule. And as I said, this would be opportunity to catch the error before patient proceeds to the exam. Sample questions for the central scheduling script, for example. We have something like this already at the Mercy Hospital at central scheduling. So, for example, they can ask patient, are you called back for additional views? They can ask for no and yes. Answering yes automatically prompts them to schedule diagnostic exam, which means patient already had screening and they're calling back for additional views. And that's diagnostic mammogram. Also, they can ask them, do you feel new or enlarging lump? That would automatically qualify for diagnostic order. Do you have a nipple discharge? Also. Do you have a history of breast cancer with or without surgery? Are you calling to schedule 6 months follow-up? Also diagnostic. Are you under age of 35? This is also a very interesting question, because at my hospital where I work, if patient is younger than 35, most of the time they only have breast ultrasound unless they have a lump that's really palpable and protruding. So answering some of these questions, actually all of those questions, would prompt central scheduling in some right direction, which type of order they can schedule. Still, even regardless asking these questions, they can still need to verify the patient has correct order. Sometimes when patient is on another line calling and trying to schedule a mammogram, central scheduling is calling us and asking us, did you get a referral? It was faxed over from the doctor's office. Is the referral diagnostic screening? And many times patient surveys, we can find out from them and learn that patients are very frustrated because sometimes it takes up to 45 minutes to schedule just for the diagnostic or screening mammogram. And as I said, ultrasound order for diagnostic mammogram is a must. They have to be accompanied by the ultrasound order. Third step, as I said, would be educating registration or front desk. Same as with the central scheduling registration people or front desk staff, they have no medical background or education. They're more administrative staff, and their main focus when patient comes to the exam is to take their ID, their insurance card, make sure everything is valid, everything is current, and they really don't pay attention, and it's, as I said before, it's difficult for them to know which type of exam patient's supposed to have. So at this point, error is already made if there is an error, but at least providing them with some kind of guidelines or cheat sheet would be helpful also, because at least right now they're waiting to be registered. If they catch the error, they can come right away to us, to the manager, so she can start working on obtaining new exam, instead proceeding, registering patient, having them changed and waiting for exam, and losing even more time. Last step would be educating patients. This would be really helpful, but this is proven to be a very challenging part, because many patients have a different level of health literacy, and if they don't really understand what we're trying to explain to them, it's not going to be so much useful. But still, I believe we should create different pamphlets that have information about specific exams. For example, if a patient has a diagnostic exam, we should have a pamphlet that is explaining, if you have a diagnostic exam, you're going to be waiting maybe a little bit longer today. You're going to be seen by a mammography tech who's going to take pictures. Then you're going to wait for radiologists to review your pictures. And then you might be required to have a breast ultrasound, which is done by another technologist. So that's why this wait time might be a little bit longer today. I think this would help, because they would ease patients' anxiety, and it's easier when you understand and know what's ahead of you, how long you have to wait. It's different than you're just sitting there for 30, 40, 50 minutes, even an hour, and you don't know what's happening. So we can avoid all this anger and frustration on the patient side by this. Another thing that we also trying to do at Breast Center I work with is calling patients a few days ahead of the exam, especially the diagnostic patients, making sure they have exams, making sure the order is correct, and they need to bring that order with them. But this is a task that requires additional staff and additional time. If we say that we have 50, 60, 70 exams per day, at least 20 or 30 of them are diagnostic exams. So you can imagine how much time it's required if we have to call each patient and remind them. So this is a great idea, but not always possible to do. When I think about my Capstone project and how timeline and the steps for implementation of this project, I was thinking to divide this in 3 weeks. In first week, my manager and director of radiology, of course, they're going to meet with chief medical director, central scheduling and registration managers, and they're going to discuss the issue that we have and plan for improvement and how we can improve in this area. Week 2, managers and leaders of each department, they're going to discuss and plan with their staff, and they're going to distribute those guidelines and pamphlets and cheat sheets. And staff is going to get familiar with those bulletins and everything. And in week 3, each department is going to start implementing these new changes and everything that we agreed upon. When I was doing this project, before I started doing it, the question was, who do I need to buy in this idea? First person I went to was my manager, of course, because she is the one who knows all about this problem, and the person who's responsible to obtain a new order when we have an incorrect order. So, and I don't know how it's with other places, but I know for the Mercy Hospital, only nurses are allowed to obtain orders, not technologists. Of course, the director of radiology, he is motivated by reducing wasted hours that we waste by correcting these errors, instead delivering patient care and doing exams. And of course, this is going to improve patient satisfaction scores because we're going to have less mad and frustrated patients. And technologists also, they're going to be interested, of course, in this because me as a technologist, I know how much frustration this causes on my end. And we easily get backed up. Another patients, they're on time, they're waiting, they have correct orders because we spend too much time dealing with the correcting the order errors. So I think all these sides are going to be interested, and they're going to buy in my idea. Of course, every project has obstacles and roadblocks, and this is the same thing with my Capstone project. One of the obstacles that I recognized is going to be difficulty to communicate this message with the doctors. Remember, I said we're going to talk with the chief medical director, who is in charge of the doctors and residents in the hospital. But we still have the doctors outside of the system, Mercy system. They're going to send patients, and he's not going to be able to talk to them. So those are the doctors that we still, actually my manager and director, they still have to address, and they have to find the right way how to approach them and discuss this issue. So I believe this is going to be the most difficult part of this whole project. There is a danger of physicians getting offended and mad, and they don't want to send any more patients to us because they don't want to deal with us and they don't want to hear this from us. So we have to be really gentle here and careful how we approach this problem. Also, another obstacle and roadblock that I can see in this whole project is it's difficulty to track everything. Is everyone following it through, and then everyone is doing what they're supposed to do? Is central scheduling using the script and the cheat sheet? Are they following it through, or they just looked at it and they just threw it away? Same thing with the front desk registration. Maybe a little bit easier to monitor them because they're right there, but still when we get busy, we cannot make sure that everyone is following it through and everyone is reading what they're supposed to read and make sure the patient has correct order. So these are some of the obstacles and roadblocks that I recognize for this. After this project is implemented finally, and we have to measure its success. Every project in its success can be measured quantitative and qualitative measures. I believe the way to measure quantitative success of my project would be comparing data before and after implementation, which means we're going to see before implementation, for example, we had 15-20 errors per week, and then now after the whole project is implemented, we now have 5 or 6. So we can tell by these numbers project is successful. Qualitative measures, mostly I would say we were gonna read patients' surveys, and based on those surveys and what they said about errors and waiting time, we would actually be able to say, did we improve in this area? Same would be with mammography techs. We're gonna go and ask them, what do you think? Do you see less of these errors lately or not? And I believe some management also, my manager, my director, they can also tell by the numbers, because numbers they don't lie, they can tell did we improve and did it work or not. Resources that are required for my Capstone project are breast center manager and person I got all these statistics and information from, as well as my director of radiology, physicians that I talk to, my fellow technologists, patients, their experience, registration staff, central scheduling staff. Also, I was researching some articles, they gave me some additional information on this. And I just want to say that no financial resources were required for this project other than my time and effort to do this. This is my project, and I hope you liked it, and I hope it's gonna be, and I'm sure it's gonna be a success if implemented. And that is all for today. Thank you for watching.